Thank you for your question. Uh, Chloroquine and hydroxychloroquine has been used in the rheumatology segment for a long time. And we always quote from our clinical experience. We don't have any database of how many patients had dysrhythmia problems, particularly with coexisting comorbidities. So we were almost certain, we were convinced that patients could tolerate hydroxychloroquine and chloroquine better than their Western counterparts. However, conviction is one thing, but there is no evidence. And the US FDA has recently reported the arrhythmogenicity, and it has recommended that it should not be used in post-exposure. As of we are left with focus. Whatever our personal clinical convictions may be, we have to keep that aside. FDA warning is a grave warning, and every treating physician or whatever is liable to prosecution if the patient loses his life after a FDA warning. So I would say, as of now, hydroxychloroquine is definitely a good drug for prophylactic use in healthcare professionals like doctors, sisters, paramedical staff, radiology staff, or even police personnel, bus drivers, transport operators, and the like. And however, there is no scope for treatment with hydroxychloroquine or even post-exposure prophylaxis with hydroxychloroquine.
I'll just put in one little bit is that I think the Supreme Court in India has said that there will be no medical legal prosecutions for COVID treatment. And the second information is that the ICMR recommendations came because we use it in a much lower dose than that has been used in the West. So maybe our complications were less, as you have said before, but basically the prophylactic measures that we use, the dosage will be low, right?
One thing, 13th June ICMR recommendation is to withhold hydroxychloroquine for the patients actually infected with COVID or post-exposure prophylaxis. They have forbidden it on 13th June.
Right. So the prophylactic use is still on. And I know of so many persons after reading all that, especially what President Trump had to say, etc., all that hoopla, doxycycline and ivermectin, which is an anti-parasitic drug. And from what I read about it, Dr. Tahir from Bangladesh, they had respiratory problems, whatever patients were coming in, and they were putting them on doxycycline and ivermectin. And they said that out of 60 patients, all patients are cured with 1 to 4. Now, this is not a classical trial. It is not a randomized RCT trial, but they are very, very enthusiastic over it. And I think ICMR is also doing some trials on that. So what is the time to use it? And the main thing is that it costs only 25 rupees, the ivermectin, and the doxycycline also is pretty cheap. So
I have no experience of using ivermectin. Doxycycline is a safe drug and it is recommended in the treatment of COVID infections when there is a pulmonary involvement. Routinely, I have no experience, so I cannot quote it. There should be RCTs, and if it is proved, this will be a very good substitute for treatment in our country. However, having said that, I will say the early first 5 to 8 days of infection is the most important thing, and it takes that to diagnose. It takes about 5 days, so we should not lose that precious time by giving medicines which have no proven efficacy. That is my take.
Yeah, I think what they did was the respiratory problem, whatever patients were coming, they tested. And when it was positive, they started giving this medicine. And their experience is that in 1 to 4 days, they had remarkably good results. But as you say, there are no classical trials. ICMR is carrying out a trial. I think they're doing it in 2 of the Delhi hospitals. So we have to wait and see whether what the proper trials and the results that they give. Question 4. Oh, sorry. Question 4 is antivirals. And this is the real clincher. Your views on remdesivir after Dr. Fauci and all recommended it in a limited degree. First, is it available? And second, when is it to be used? Is it effective in severe cases?
Well, remdesivir is possibly the only ray of hope in the treatment of COVID infection. Uh, First, we started with antiretroviral drugs, but they have been shown to be absolutely ineffective in the treatment of the disease. Secondly, with remdesivir, regarding the question of availability, it's a emergency use drug and it is available everywhere in the world. It is available, it will be available for sale and use in India also by the end of this month. And basically, certain trials have been conducted throughout India in the big teaching hospitals and some other corporate hospitals are using remdesivir. Only thing is, when you use it, you have to use it early. You don't wait for the patient to be on a ventilator. So, moderately severe patients, you start remdesivir as early as possible, because once your patient is ventilated, the chances of reversal, even with remdesivir, is very low. And we have to use, if it is used early, it's a 5-day regimen. If it is used later, it is a 10-day regimen. And one thing is very encouraging. The Ministry of Health and Family Welfare, they have given a protocol dated 13 June 20. And that gives us the right to use remdesivir under emergency use authorization. And we'll be delighted to know that some Indian pharmaceutical companies are coming up with most moderate degree of moderate severity of patients on oxygen, not on ventilator. It's a very good drug, but once you ventilate the patient, the chances of reversal are less. You have to be sure that the patient doesn't suffer from chronic liver disease or a chronic renal failure with a eGFR less than 30. Pregnant or lactating females should not be used, and children less than 12 years of age should not be used. The recommended dose, this is not required basically. We give a loading dose on the first day followed by 100 milligram daily for 5 days for early patients, and patients already on ventilator or in the later phase of the disease, we use 10-day course. Main thing, it has to be used early, and that is the only rescue that is available to us as of date. But it does not reduce mortality. The main difficulty, it shortens hospital stay, prevents patient being transferred to ventilator, but it does not reduce mortality as of now. So what should be the way forward? Perhaps we have to use remdesivir as early as possible. We don't wait even for patient to sharply deteriorate.
Yeah, approximately the costing is going to be about 7,000 rupees a day for 5 days. That's what they said. And as you said, the Indian companies are coming in by the end of June.
Yes, yes.
Much less.
Next month, it will be very cheap.
Yes,
it will be affordable.
That's encouraging. Okay, question 5, anti-inflammatory treatment. The real thing which made such a splash recently is the steroids and its role in the immune storm treatment. We all know that there's an immune storm in this COVID, which is really dangerous. So, what would be your thing on dexamethasone?
So one thing I'll try to correlate this with a rheumatological condition. Basically, there is a incubation period followed by a viral proliferation phase, and post-viral proliferation there's an inflammatory phase. So everything adds on to the inflammatory cascade, and accumulation of inflammatory cytokines causes tissue destruction. And this tissue destruction is basically in the lungs. It could lead to accelerated inflammatory changes in the vascular endothelium also. And with that, that leads to a hyperinflammatory vascular state akin to Kawasaki disease in the children. So basically, it is a hyperinflammatory syndrome with associated vascular changes in the cardiac, in the renal and all other arteries. And another thing, it is prothrombotic. So there are so many things that can happen. So it is all a sequel to inflammation, accelerated inflammation. And by general logic, anti-inflammatory drug, the most best anti-inflammatory drug is prednisolone. The prednisolone, when it was discovered, the, the Nobel Prize was given just 1 year later. So it is a life-saving drug if it is judiciously used and in good hands. So basically, what we have to do is, this is basically a cascade of inflammation resulting in cytokine storm with tissue destruction, as well as a vascular prothrombotic state. And so treatment should be with anti-inflammatory drugs. Steroids have been proven of recently. Last week, there was a publication mentioning that there is a dexamethasone is very successful in reducing the period of hospital stay, but that again, before the patient is on a ventilator, that has to be used. And it should be a very short course, 3-day course of steroids. It could be dexamethasone, it could be methylprednisolone.
A couple of things I'd just like to add on here. Dexamethasone is not new to us. I mean, we have been using this, not us particularly in orthopedics, but you and all have been using this for a long, long time in these situations of respiratory distress. The trial which came out was from England, where there were 2,104 enrolled patients who administered 6 milligrams of the drug for 10 days and was found to reduce deaths by 1/3 in ventilated patients and by 1/5 in patients receiving only oxygen. So much so that the lay press said that so many deaths could have been avoided had this been done. That's a bit empirical, but certainly this is another thing in our armamentarium to treat these patients. Okay, question 6. And this is exactly what is this COVID-19? Is it a vasculotropic? Is it a intravascular coagulation, PIC, or a pulmonary intravascular coagulation? Or is it a pulmonopathy, where it attacks the alveolar cells? And we know now that this has been linked to this Kawasaki disease and the Lemierre syndrome. And there's a finding by Shandip Chakraborty from IIT, who said that across the globe they show a distinct pattern. Anaerobic bacteria like Prevotella seems to predominate, as there is disruption of balance with aerobic counterparts. Now, all this, but the principal question remains: is it a DIC or a diffuse intravascular coagulation, a pulmonary intravascular coagulation, or is it basically attacking the alveolar cells?
It is both. Basically, as I've already mentioned, hyperinflammatory response leads to vascular involvement, and it could be precipitate the different cardiac deaths, peripheral vascular disease, including thrombotic states. However, apart from this thing, there is also, as you said, it is a pulmotropic. Pulmotropic means basically it is affecting the lungs. In one sense, it is affecting the lungs and producing typical ground glass opacities on the HRCT. So in certain cases, when you get the cases early, patient presenting with an influenza-like illness and presenting with a severe acute respiratory illness or distress, you get the RT-PCR for the nasopharyngeal swab is negative, but you get a telltale CT scan showing pulmonary infiltrates, characteristic of interstitial lung disease, ground glass opacities. So that clinches the diagnosis. We say it is basically likely, highly probable that is it is COVID-19 affection. So basically there are vasculopathic manifestations, there are pulmonopathic manifestations. There may be predominance in one person, it may be predominant in the other person. So there are two different subsets, but there's an overlap. And number two thing is basically regarding the bacterial etiology, more works to be done. It is a question of time before we can finally say whether anaerobic bacteria is a primary cause, it is a secondary cause.
Right. So, so therefore, that leads to this the anticoagulant treatment, which was given a little bit empirically, I thought, or no molecular weight heparin or heparin. Do you think that will be a great help in this, or is it just what we are learning from it?
All patients who are hospitalized have to be given prophylactic anticoagulation. So it is universally indicated for all patients, because as long as the patient is mobile, even the prothrombotic state doesn't cause so much worsening. Otherwise, you can develop DVT, you can develop pulmonary thromboembolism, you can get accelerated cardiovascular complications. So many things can occur. You can get MI at an early age. So if you want to prevent it, if the patient is a high-risk individual, in that case, we definitely have to therapeutic doses. But in all cases, we have to give low molecular weight heparin in a prophylactic or preventive dose.
That brings us to the question on aspirin, because there's all this social media videos going on which says that aspirin is the new wonder drug, and that has to be given, and the real attraction is it's cheap. So what is your take on this aspirin treatment for this?
Well, aspirin is not universally recommended in the treatment. Particularly, it is to be avoided in early cases. It can find use in special situations, particularly in post-COVID coronary artery disease or peripheral artery disease or such situations. So where it can be taken only on medical advice. It should not be a blanket administration. Low molecular weight heparin or unfractionated heparin in preventive doses is recommended in one and all cases of COVID-19.
So the next question is the big question, is the BCG and oral polio vaccine. Any role in adults? I know one of the theories is that since many parts of this part of the world has been subjected to this in their childhood, that gives them a low rate of COVID infections as such, or COVID mortality. And is there any role for it in
Yes, actually, there was a study in PGIMER Chandigarh and Dr. Devi Dayal's group. They endorsed the link between BCG and low case fatality rates of COVID-19 in India. So compared to the Western world, where the mortality rate is definitely higher, patients in India are immunized with BCG, and their outcome is better. That has been studied in this article, and this article said that can existing live vaccines prevent COVID-19? It was published in Science, explored the non-specific immunoprotection that live attenuated viruses can have. However, this is purely speculative, and to the best of my knowledge, there is no statistical link established yet. But there are studies going on in PGI Chandigarh, and this soon there will be more information on this available.
Right, there were 2 clinical trials underway, and who does not recommend BCG vaccination for the prevention of COVID-19 in adults as yet? Let the trials come out what they say. Okay, vaccine. When will it come? Well, that's a burning issue everyone is looking for, and so many trials are going on. The Russians are going to third place trial, the Britishers are there on it, and there are Indian companies who have signed on to manufacture it before even the trial results come. So, vaccine, when will it come? What do you say?
So once we know that this virus has come to stay, maybe for 2 years, 3 years, the only way out is basically a vaccine, and every one of us is wishfully thinking it will come fast. But according to previous vaccination discoveries, it is always taken a period of at least 2 to 3 years for the vaccine to be tested and be online and safe for administration. You see, there is no dengue vaccine as yet, although every year so many people in India die of dengue. So I will remain rather guarded and hope that perhaps by June 2021, some vaccine could be developed at the earliest. It is best not to get our hopes up at this stage.
Yeah, these trials are going on. Let's see if it comes. It may come out earlier. So people are optimistic. Let me ask you a frank question straight away. If the vaccine comes at this stage, say in October, November, will you take it?
There should be a long trial before you administer the vaccine, because it has been shown, like the dengue vaccine was definitely proved to have adverse effects, and then it was discarded. So it has to be tested reasonably over a period of time before the safety of the drug is established.
Okay. When will the peak come? If people are looking at the peak, when will the peak come? Because everyone hopes that after the peak, there'll be a downfall. So what do you estimate? When will the peak come?
You see, I have spoken to my epidemiologist friends, okay, and they say they are of the opinion that in India, basically there are more than one epidemics. Maybe every state has an epidemic curve of its own, but in general, the trend is possibly we are nearing the peak. Maybe July, August, there will be a peak, and it will flatten out by September. Of course, there are some conflicting reports published in the name of ICMR that peak is expected to be in November. But as far as I'm concerned, I have checked that that person is not associated with ICMR. However, uh, the peak is likely to be in September, but definitely no one can vouch for it. So whether it is September or November, it will definitely reach a peak and then flatten down and go downward, but it will be there to stay.
Right. That's as far as the present moments in this part of the country goes, we are rising. We're rising. We haven't yet reached the peak, but let's hope it comes earlier than later. It probably may mean that a little bit of consolation for all of us. Okay, convalescent plasma therapy. This has been a big thing which is coming in a way, and as you know, the health minister who was tested negative and attended a high-level meeting with the home minister, he was negative, but 2 days later he turned out to be positive. And now they're taking him to one of the bigger hospitals and they're putting him on convalescent plasma therapy. So, your take on that?
You see, convalescent plasma therapy is a very good option for us, particularly in the city of Calcutta. We have a central blood bank, we have so many blood banks and so many donors, so many patients of COVID, and we can get the plasma of the patients recovering from the disease, and that is at a very low cost and a very easily available. Remdesivir will not be available, even if it is available, it will not be affordable to everybody. If it is affordable, fine. But remdesivir has to be used before ventilation. If a patient comes very critically ill, even after ventilation, you can give convalescent plasma therapy, and it is very easily available, and it will be cheap, and the side effects of therapy after screening for hepatitis B, C, HIV, etc. are much less. The only thing is, according to the Ministry of Health and Family Welfare Clinical Management Protocol dated 13th June, convalescent plasma off-label may be considered in patients with moderate disease who are not improving. Oxygen requirement is progressively increasing despite use of steroids. And next slide, please. And we can actually give it very safely. One catch point is which phase patient has plasma should be collected. You see, patients already convalescing with serum IgM antibodies. If that plasma is transfused, then we get good response. Patients with only IgG positive, low IgM levels, that is delayed recovery patients, they will not produce the same result. So that is one thing that has to be borne in mind. So we have to screen them for IgM or IgG antibody. If the IgM antibody is high, that plasma can be used. It's a very good substitute for remdesivir or other costlier drugs, and is affordable and it can be offered to more number of patients. That is what I feel.
I think it's been started in Kolkata on an empirical basis and trials are going on. So that's one encouraging thing. Move on to this on the convalescent plasma therapy with the special prerequisites.
So before placing the patient on convalescent plasma therapy, these things have to be checked. Compatibility, as in all blood products. Then the neutralizing titer of donor plasma should be above the specific threshold. The plasma IgG titer above 160, 1 in 640 should be used. Recipient should be closely monitored for several hours post-transfusion for adverse effects, and use should be avoided in patients with immunoglobulin A deficiency or allergy. So, ministry recommended dose is given here. Next.
Herbal products. And now you know that herbal products are very much on, especially in India. But the Chinese also are into herbal products, and these have a huge layperson following. So your take on these herbal products and what do you feel?
See, healthy diet should be taken by everybody. So that includes herbs, seeds, vegetables, whatever you take. However, Ministry of Ayush in India have stated that majority of people under quarantine who preventive measures suggested by do not develop symptoms. However, there is no data or peer-reviewed research on this publicly available. However, there's another article in the magazine Science developed in Madagascar as it could fuel drug-resistant malaria in Africa.
So at the present moment, it's still empirical, but there are people who are having it. So I don't think there's any difficulty in having it before you're infected, or you're say very, very, very asymptomatic and you're tested negative, etc. That's good, but we're not quite sure as to the efficacy of it on scientific terms. Now these two drugs, the nitazoxamide and the its metabolite, isoxanide. So these have shown inhibitory effects against SIBA in the LNC-MK cells. So what is your take on these two drugs? These are not very common, but this has also been discussed.
Actually, trials are on basically to provide data on the activity, either alone or along with hydroxychloroquine. And now hydroxychloroquine has been banned. So against this virus, however, as of now, there is no publicly available supporting evidence for this dose against the virus. I have no experience of using this, so I cannot say about it.
Okay, so anybody more interested can read this reference that is there. Okay, colchicine and antidiabetics, any role?
I don't think so. That these are more theoretical. Some person does some experimental work. Unless it translates into clinical practice, it is not documented, is not recommended at present. Yeah, there are only handful of drugs, 4 or 5 drugs, which may help in the treatment of COVID-19. All these add to confusion.
That's it. That's the whole reason why we decided to do this. There's so many confusing evidence and persons are coming out with this, so we need to know about it. ACE2 receptor blockers. What's your take on this?
Hello. Just a minute. Just a minute.
Yeah.
Please.
I think he's gone off a little bit.
Just a minute, please hold on.
But if the slide is on and you can read it, that there is.
I can't see it from here.
There is no certainty evidence that patients on long term. Okay, can you see?
Okay, fine.
Go ahead.
Go on to the next slide, please.
This
ACE
is
inhibitors.
ACE2 inhibitors.
Yes, there is no certain evidence that patients on long term with ACE inhibitors or ARBs are not at higher risk of poor outcomes. To the best of our knowledge, no evidence of increased protection. So that is the gist. no evidence of increased protection with these sort of drugs.
So that's another confusion which is done. Okay, tocilizumab. The Japanese have done a great trial on this, and you have, I think, great knowledge on this because it's basically an anti-rheumatoid drug, anti-inflammatory drug. So,
This is a wonderful drug to use. You can use it patients on ventilators also. Basically, it's a very good systemic anti-inflammatory drug, and we have experience of using it in rheumatoid arthritis and systemic onset juvenile inflammatory arthritis, macrophage activity. That is hyperinflammatory states. We have it may be considered in patients with moderate disease with progressively increasing oxygen requirements, and even in mechanical ventilated patients who are not responding to steroids. The long-term safety has to be worked out. It is not known because the disease is almost 6 months old. So we don't have long-term data. We have to get randomized controlled trials. But as a life-saving drugs, whatever access I had, I heard, I discussed with one of my colleagues. In Maharashtra, they have used in 5,000 cases this tocilizumab as a trial, and the results were quite promising. So that is one thing. It is very promising. After remdesivir and convalescent plasma therapy, I think tocilizumab is the only space. And for the first line, corticosteroids.
so just a footnote to add, this is basically an IL-6 inhibitor. And Tamil Nadu is getting 1,000 of these drug pieces from USA. The cost is 92,000 rupees. That's fantastic, and it's sold in the black market for 1.3 lakhs.
But
So
I can assure you, one thing,
it's going to come now, right?
I can assure you, cost will not be a concern. If it is required, the cost equation can be mediated by the government and it can be come down.
Fine, let's hope so. That's another thing that's on. So this is your special considerations of its use.
So one thing is basically we have to get proof of the raised inflammatory markers as in CRP ferritin. This is very technical. And we have to monitor for secondary infections, neutropenia, and tuberculosis and active infections have to be screened as with all immunosuppressive drugs because that leads to activation of infection and tuberculosis. And this is a recommended doses. It is not necessary, but basically it is a wonder drug. If you establish that it is required and if you exclude infection and tuberculosis, then use it. Don't wait, use it. The chances you will succeed.
So steroids, then convalescent plasma, then this. Okay, so things are not that bad.
Remdesivir is coming in a very big way and tocilizumab is available. These are the only 5 treatments.
Nitric oxide and epoprostenol, these are pulmonary vasodilators. Do they have a role to play?
Yes, actually that thing came from a very interesting story. Can I have the next slide, please? Basically, one physician, lady physician in USA, I think, she was infected with COVID-19. She was a patient of primary pulmonary hypertension previously. And during the COVID infection, her pulmonary artery pressure peaked very high. And this group of drugs, this nitric oxide and epoprostenol, these prostacyclins, basically, they help to lower her pulmonary artery hypertension, correct the hypoxia. This led to a clinical trial, the Pulse COVID-19 001. This is a randomized placebo-controlled phase 3 trial approved by the FDA. It was approved this week only. It is aimed to look at the efficacy and safety of the nitric oxide delivery system in 500 COVID-19 patients who require supplemental oxygen before the disease progresses to a point where mechanical ventilation is needed. So if we can correct the pulmonary hypertension with nitric oxide or epoprostenol in patients of COVID-19, reversing pulmonary hypertension can prevent the patient going on ventilation. Because if you ventilate that patient of pulmonary hypertension, 99.99% that patient will not come out of the ventilator.
That's another interesting point. The vitamin C, antioxidant, antiviral, and this has been said in all over the place. So, what is your take on this vitamin C?
Is it vitamin C intake in diet, whatever we take, that is in no way sufficient to ward away infection. It is very good to take this patilebu or whatever you say, these things, but the dose that has been tried in trials, RCT in USA, in 167 patients, sepsis-related indicate ARDS, that administration about 15 grams per day of IV vitamin C for 4 days may decrease mortality. So that is a huge dose. And studies need to be done whether or not it is actually effective, because just taking vitamin C by mouth, as I see in prescription, 500 milligram BD or 500 milligram OD is absolutely useless. It's worse than a placebo.
Okay. So the sequence of increasing hypoxia treatment, we tend to forget that the primary therapy in all this is oxygen. And that's one of your great information which you give to everybody. So we start off with this oxygen therapy, the oxygen first challenge, HFNO, NIV, all this is a little bit technical, but we'd like your idea, your information on this, on these aspects.
You see, the saving of the patient of COVID-19 depends on correcting the hypoxia. If you have a mild disease, you don't need hospitalization or special therapy. Moderate disease, we have to be very careful. And as the patient, I have spoken to certain patients who could not go to the toilet, which was adjacent to their room. And they're in so much pain and so much breathless. So that is the stage when treatment is required. And we have to identify patients and give them correction of oxygen, low oxygen state. And that is the most important thing for, and keeping in mind that this disease is disseminated by respiratory route. So we should not go in for a high flow nasal oxygen at first. We should start with low flow nasal oxygen, because even high flow nasal oxygen can lead to the dissemination of the virus. If it is not corrected with low flow, then we go for high flow. Then we have to go for other things, like we have to encourage prone ventilation. Keeping the patient in the prone posture for the 2/3 of the day or even more, that helps in redistribution and improve oxygenation. Then in the early, if this is not sufficient, we have to go in for other measures. I will not go into the technical details. We go in for mechanical ventilation and intubation at the last. Before that, we have to ensure we go through the different stages, and ventilation is not the solution, because as we have learned in the discussion, that not all cases are basically due to pneumonia. There is a large segment due to other causes, and that group will not benefit from ventilation alone. So we have to correct it by other measures. We have to be aggressive in treatment with remdesivir, with corticosteroids, with, if remdesivir is not available, with tocilizumab. And these are the only two good options. We can buy time with convalescent plasma, and we should not rush with ventilation. And another thing I would like to add is basically, there are certain cases in which there is pulmonary failure as well as cardiac failure, and these subjects lose their lives very miserably. To help them, we can take access of the extracorporeal membrane oxygenators. Very few are available in our city. There is a unit in SSKM IPGMA hospital. There are units in certain private corporate hospitals in Calcutta, very few. And treatment in this is very difficult to afford, not affordable by all, but it should be extended to critically ill patients who can afford it.
So basically what this does is this, that the blood is pumped outside of your body to heart-lung machine, which removes the carbon dioxide, sends oxygen-filled blood back to tissues in the body. And the blood flows from the right side of the heart to the membrane in the heart-lung machine and then is rewarmed and sent back to the body. So basically this method allows the blood to bypass the heart and lungs, allowing these organs to rest and heal. And ECMO is therefore used in this critical care situation. The heart and lungs need help so that it can heal. May be used in care for COVID-19, ARDS, etc. But ECMO, I think, is has what is right. So this is ECMO. And so, Samar, if there's anything more that you would like to add when we come to this, as we conclude this session nowadays, anything that you would like to add?
I think, first of all, there are two facets of dealing with COVID. Number one is spreading. We have to halt the spread of the disease. And for that, the containment measures, the classical SMS, social distancing, masking, and the sanitization. These three are the keywords. And in treatment of COVID disease, I would say early identification of the disease is very important. And the main difficulty, particularly in this rainy season, there will be so many chest infections, so many upper respiratory and combined chest infections, which will be very difficult clinically to distinguish whether it is pneumonia or viral infection, or say some adenovirus infection or coronavirus infection. It is very easy to discuss in slides, but ultimately the test hinges on, number one, the nasopharyngeal swab, if it is done early, and if we are delayed in doing it by the 7th, 8th, 10th day, then we have to depend on the bronchoalveolar lavage or for the sputum for confirmation of the virus. And second is basically we should diagnose it early. We should not miss HRCT. It has to be done in every case. And in critical cases, most important thing is ensuring the airways, the oxygenation is kept correct. That is very important. Second, we should step in early aggressive treatment. Where is the patient is hypoxic, the patient, we have to correct the hypoxia, we have to identify the cause, and we have to treat. Steroids, if necessary, have to be administered early and in short course. Where there is necessity, remdesivir should be stepped up. Remdesivir should be applied in more cases because it is becoming more affordable. And ultimately, I personally believe remdesivir will be the way out in addition to corticosteroids and tocilizumab. In our country, convalescent plasma therapy is definitely very supportive, barring the hazards of any blood product transfusion. So that is my take from whatever little I have read or searched or have idea about this disease.
I think that's been a great information that you've given us. So COVID brings about a sense of desperation and helplessness. But listening to all this that is going on, you feel that the medical personnel and the scientific community are there trying to find out solutions. And that's a great thing which is going on. So thank you, Samar.
Thank you.
We are in a slightly limited time also. But anyway, and thank you all for listening in. This is being recorded and we'll put it up on a YouTube thing and give the link to all those who are there and everybody else so that they can look back on this and take their information from it. I think this has been great topical information, it's cleared up a lot of problems, a lot of confusion. And we go back today probably more informed, more confident, and more sure of the way that treatments are going on. So any questions? Any questions to anybody? Just unmute yourself and ask them one by one. Raise your hands and ask them if you can. So
no questions.
There will be
Samar,
questions.
Samar, can I ask you a question? Rana here.
Definitely, most welcome.
any take on vitamin D? There is a recent study which showed that people who have high levels of vitamin D seem to be protected against the progression of the disease. Any take on that?
You see, there is report, but that is not substantiated. So it has to be, I think it has to be validated, larger number of patients, proper trials. There are actually so many papers coming out recently regarding COVID. I think that has to be well worked.
Thank you. Thank you.
Any other questions? Yeah, go ahead, please.
I'm not from the medical profession. Just wanted to know that how long at a stretch one should be wearing a mask.
As long as you are out and exposed.
Does that create any kind of a problem because you're sort of inhaling your exhaled air to quite some extent?
No, I don't think so.
Okay, thank you, sir.
Because when you are admitted in a hospital, in a critical care unit, you are having either influenza or COVID or adenovirus, you have to wear the mask continuously. So that is no reason. You have to change the mask after some time. That's a different thing. But as long as you're outside and you have either chance to spread it to others or contract some infection from others, you should wear the mask, definitely.
Thank you, sir.
Yeah, BB, I must just add, number one, that you have to wear your mask properly. One of the major things which I see nowadays with the lockdown going out and people moving around, there are no masks. There are masks which the nose is uncovered, there are masks which the mouth is uncovered, and there are masks hung on the neck, there are masks hung on the stomach, there are masks kept in the pockets, and when you glare at them, they suddenly take it out and put it on. So the mask wearing is something which has to be developed into habit. It's not easy. We as doctors and we as surgeons use this mask, and we have to use this mask with other things, and it is painful. I agree with you. But this has to be used. This is sort of what they call the new normal or the future normal. And unfortunately, one cannot say how long. We would recommend really at least when you're out, as Sean has said. But the other way around is we can't really use this mask for a very, very long time. There's special masks, and especially the ones which are antiviral protections are the best of the lot. But then beware of masks which carry the N95 mark, but which is not an N95. So there are masks all about, but generally speaking, for laypersons, a good mask covering the mouth, nose, etc., worn properly is good enough. But you have to wear it. That is fundamental. It's the best way that we have of tackling further spread of disease.
Thank you so much, Indrajit. Thank you.
Samar, one last question. Samar,
Yes.
what's your herd immunity?
Herd immunity. India's population has to be reduced by 20% at least to develop herd immunity. If we are prepared to take that, then definitely we should go in for it. 30 lakhs, 30 crores people mara jabe, then we'll have herd immunity.
That's a good one. That's a good one.
Yes, exactly. And herd immunity without a vaccine, that's horrible. But then whether you like it or not, it's indirectly or unintentionally, we are moving to herd immunity.
আমাদের ক্লাসমেট স্বরূপ সরকারকে মনে আছে তো?
Yes, Sarup is on the board, yeah.
স্বরূপের সাথে কথা হয়েছে কয়েকদিন আগেও, মাঝামাঝি কথা। স্বরূপ বলছিল যে ভ্যাকসিনের ব্যাপারে ও খুব অপটিমিস্টিক। ও বললো দেখ, মানে এই ভাইরাসটা খুব বেশি মিউটেশন হচ্ছে না, সো এক্সপেক্টেড, কিন্তু মোস্ট লাইকলি সামটাইম নেক্সট ইয়ারের শেষের দিকে হয়তো মোস্ট লাইকলি আসবে। The chances are it will come, but only chances, আর কিছু না। ততক্ষণ পর্যন্ত মানুষ কিভাবে এরকম ভাবে চলবে, I simply don't have an answer. But there should be more responsible publications. Anybody is writing articles on a new drug on 10 patients and giving his comments, it's very miserable. NEJM, Lancet, এরা সমস্ত, their articles are turned out to be hoax. তাহলে on whom will we believe আর কি বেসিক্যালি সেটা একটা প্রশ্ন
Basically,
এসে
we
গেছে
used to think that WHO was the end of everything. But now the changing criteria done by WHO and the other organizations dented our confidence a bit. But I slowly, but I suppose they are the only ones, reliable ones we can deal on instead of that paraphernalia and that, what you said, the intense number of publications that are coming out with very little scientific background.
মানে they are not being মানে peer reviewed কিছু না করে পাবলিশ করে দিচ্ছে
Yes, that's right. So if there are no other questions, I think let me thank Samar for taking his time out, and I've been bugging him for a week, more than that, about all this. And all those who came and listened, for others, we'll get the link along to you so that you can look at it backwards and see what is going on. And probably this will cure your confusion a bit. And more important than that, it will give you some more confidence that people are moving on the right track. They're not hopeless that way, but then you have to take a big part in it and help it by helping yourself by protection. So thank you very much once again. Thank you.
Thank you so much, Indrajit. Thanks to both of you. Very, very nice presentation. Very nice.
Thank
Very
you.
clear.
Thank you.
The great are looking at you.
Best part is meeting you. Thank you.